this. Here's your code for CME. And talking about knee dislocations today, I don't really have any relevant or irrelevant financial disclosures. This is, a lot of this was put together by Dr. Fichtel, and so I've updated it quite a bit, but I did leave the Bill Gates pictures and quotes because they're kind of interesting. Television is not real life. In real life, people actually have to leave coffee shops and go get jobs. That's your first word of wisdom for today. And this study here was one that actually looked at sport-related films, and of the 78, or of the injuries, 78 were considered severe, and over a third of those, the kids went back to playing. So all this to say, what you see in the movies isn't real life. Setting expectations early is really important, especially for these pretty serious knee injuries, these multi-ligament knee injuries. They can be life-altering, career-altering, and so setting expectations early really is important. Let's see if this will pull up correctly. So you can see, obviously, his knee is dislocated there.
Dr. Bowman, we can only see your PowerPoint right now. I don't know if you're showing a video.
Let's see.
We can see the video now.
You can? Okay.
Thanks.
So can everyone see that there? His knee dislocated, and then the trainer popped it back in place right there. Here's a replay. And so oftentimes it's a player getting hit low. Let me see if I can pull up the other one while we're here.
Is that the last time Tennessee made a highlight?
Probably. Another good example, his knee is out here, and then the trainer is going to pull on it, and it pops back in place. Yeah, right there, it kind of pops back in place. All right. Sorry, it moves a little bit slower here. Okay. So some good examples there. So what the main things I want you to take away from this talk is that, first of all, you have to have a high index of suspicion. So, you know, we see ACLs pretty often, or at least, you know, we see them. But you have to be suspicious of another injury, another ligamentous injury, neurovascular injury, especially if the knee feels loose when you're examining it. So high level of suspicion. Always look at your neurovascular exam, even if it just seems like it's something simple and straightforward, and repeat exams as well. So anytime you suspect a knee injury, you should be looking at this and documenting it as well. And then also, as I mentioned before, set expectations early. So this is a case that I believe Dr. Diamond was involved with. Women's basketball player went up for rebound, hit while landing, her knee buckled, and said it went out. And this is the first injury that she's had to the knee. So pain, it's grossly lax both anteriorly and posteriorly, but it's not dislocated. It doesn't seem to be the patella. So questions we're going to answer: how common are these injuries? Can you have a knee dislocation even if it could have it been a dislocation? Now it's auto reduced. And then what treatments do you do both initially and long term? So obviously something like this is going to be quite obvious. The femur is not on top of the tibia anymore. So basically the definitions, loss of articular congruence, which would certainly be that, or 3 or more ligament disruptions. So if you, in order to dislocate the knee, you have to disrupt multiple structures. And so both of these definitions have been used as far as being portrayed to dislocations. Epidemiology-wise, the vast majority of these, or at least 50% in this study, spontaneously reduce. But think about even just an ACL injury where you get the bone bruising. Obviously, that knee went to a different position than it currently is. It's currently in, and so to varying degrees, you can have some subluxation or dislocation, but at least half of them, at least in this study, spontaneously reduce. So high energy versus sort of low or medium energy is typically what we're seeing is more of the athletic population. But then there's also this very low or very low energy mechanism where somebody just has a fall. And so also becoming much more common. And this was a study out of Memphis. And in this cohort of patients, there was actually very high incidence of nerve and arterial injuries. And so that these injuries, especially in the obese, are seems like a much more traumatic than you would expect, because they do carry so much more mass. And so, Dr. Scott and I had seen somebody previously. She fell down the hill and basically had torn all 4 ligaments to some degree. So something you need to think about and be aware of. I've also, I trained in Memphis and would have patients. I remember clearly a patient that came in about a week after having a knee injury. She was just placed in a knee immobilizer, an outside facility, and came because her leg was going numb, and she thought she was having circulation issues, and sure enough, her knee was subluxated. She had a multi-ligament knee. She ended up requiring, she had a vascular injury, pseudoaneurysm. So, and obviously the providers that were seeing this at first said, well, she just twisted her knee and just sent her out. But something you certainly need to be aware of, especially as our society grows. So here's the second case, 35-year-old. This is when I was mentoring. Was walking up a hill and tripped, and her knee felt loose. She had normal x-rays, but she had a very loose Lockman. So anterior and posteriorly, she was loose. She had grade 3 varus stress, grade 2 valgus stress. Her perineal nerve was flickering, but certainly she had injured it as well. BMI was 60. And so then we get into, there's some other beasts. So, prosthetic dislocations. But then as far as classification, there's a few different schemes. This one is pretty basic, anterior, posterior, or rotatory. The one that you'll see most often is the KD. And so 1 is a single cruciate with collateral. 2 is ACL, PCL, but the collaterals are okay. 3M is ACL, PCL, and the MCL. 3L is with the lateral side. And then 4 is all 4 ligaments, and 5 is fracture dislocation. And so as far as how common these are, it varies depending on the study you look at. But this is sort of the breakdown of what you'll see when they are considered multi-ligament injuries. Here's another quote. I choose a lazy person to do a hard job because a lazy person will find an easy way to do it. All right, so you're on the field and you see this happen. You want to, if you didn't personally see it, you want to talk to the trainers, etc., and say, what did you see? Because they may say, I ran on the field and pulled on it and the knee popped back in place. It's usually, they feel a pop and they may have paresthesias running down the leg. And you want to know how long it was dislocated if it was out. If you're there on the field, obviously you're going to know. But if you're in the emergency department or in clinic and you have no idea, you want to ask how long it was out. And oftentimes it is an exaggerated hyperextension type injury. So you want to obviously do a good physical exam. The first and last and middle thing you do throughout the course of the evaluation is your neurovascular exam. You want to check to make sure that perineal nerve works, that they can dorsiflex, and try to grade that strength. Note if they have any sensory deficiencies. Note their pulse exam compared to the other side, and then of course your knee ligament exam. So the hard vascular signs, of course, if there's active hemorrhage or expanding hematoma, if there's absent pulses, these are going to be giveaways. And sometimes that, especially with higher energy trauma, it can be pretty dramatic. But what is dislocated needs to go back in. So typically it does if you pull some longitudinal traction, but occasionally it doesn't. And if it doesn't, then you have to think, well, what is entrapped? And this is called the dimple sign, so the medial femoral condyle buttonholes through the retinaculum here. And so the MCL and the capsule get interposed, and no matter how much you pull on that, it's not going to reduce, and that's something that needs to be typically open reduced. You could have medial meniscus in the way, vastus medialis, and here's a case example of that showing the MRI was pretty dramatic down there, how that medial epicondyle just buttonholes right through the medial structures. So the first thing you want to do is immobilize it. You want it to be in a little bit of flexion, but some type of, oftentimes you'll see these air cast type splints. Another quote, your most unhappy customers are your greatest source of learning. All right, so in the emergency department, what do? So we assess for concomitant injuries. We want to, of course, get some imaging, and then consult your local orthopedist, vascular, etc., whoever needs to be involved. This is some pictures of vascular injury and repair. I will say, for the surgeons in the group, we know this, but when oftentimes the vascular surgeons will rush them back and they'll get to work and then they'll repair it. And it's really important to communicate with them and say, hey, this knee is grossly unstable. It's going to have to be in an X-fix, and help them think about what position they're fixing the graft in. Because if they make the graft, potentially, and the knee is flexed, and you want it to be a little bit straighter, and you go to put your X-fix on and you're straightening it out, then you're going to just tear the repair. So it's really important to talk to them right at the outset, and so that everybody's on the same page. And a lot of these ligament injuries, if there's vascular involvement, they'll end up in some sort of temporary fixation. So historical data shows us that arterial injury rates anywhere around 7 to 15%. Often it's a traction type injury where you get an intimal tear rather than basically a laceration, say. And so this leads to acute occlusion. And so if you look at, based on different databases, that rate can change. By grade injury, of course, as you would think, the higher grade injuries, grade 4s, have more arterial damage, which makes sense because there's usually a higher energy. But then there's this other study that showed that even grade 3s had pretty high rates. And really the gold standard is some type of arthrography, and we'll kind of talk a little bit about the differences, but either you can see right in the center of the picture where that vessel, there's an occlusion, and whether it's CT arthrography or this is an intra-op where they use dye to do it. The gold standard is the intra-op where they shoot dye into the vessel, but the CT angiograms seem to be very sensitive, and usually if you're in the emergency department setting and there's a question, you're going to be following with that first before doing something more invasive. So why not scan everyone? Well, obviously CT angiograms are expensive, as are arteriograms, and there are complications potentially with arteriograms and false positives, etc. So that's why we typically get the CT angio first. If you look at, so standard sort of has the classic paper where they discuss vascular injuries and knee dislocations. This was in JBJS, and they talked about the role of physical exam. And so in their paper, they did really well. So of all the knees that had injuries, of the 10 knees that they found, 9 actually had injuries with only 1 false positive. But if you look at other studies, the results vary. So it seems like when they're studying it, they don't really miss these. But if you look at meta-analysis, physical exam alone isn't obviously 100% sensitive. It's maybe 80% specificity, around 91% or so. So what can we do to increase our sensitivity to our physical exam? Well, ABIs are, I would say, probably the most important tool that you have to, one, rule out or fully evaluate a patient, but 2, also to cover yourself legally. I think if you just go on your physical exam and a patient ends up having an injury, then you're potentially susceptible to lawsuit if it had come to that. Where ABI is really, if you document that and they have a normal ABI and you've kind of documented serial exams, I think you're much better covered from a legal standpoint if there is an injury. Heaven forbid it come to something like that. But anytime that you're thinking about it, or thinking that there's a discrepancy in the pulse, or think that there was a multi-ligament injury and there could have been a dislocation, get ABIs. And it, in this study here, really reduced the arteriograms that they were doing. Essentially, if your ABIs are greater than 0.9, meaning comparing side to side, where you put a blood pressure cuff and then use a Doppler to get the pulse. If it's greater than 0.9, comparing side to side, then there were really no misses. And so that's an important test to do. So it is still possible to miss things. So you can have, as I kind of mentioned, a pseudoaneurysm where you have an intramural tear, but everything looks normal initially, but then 24, 48 hours out, or even several days to a week, they develop symptoms that are consistent with a vascular injury. And it's because this intimal tear has now led to some type of occlusion or thrombosis. So, so we already talked about duplex ultrasound, CT angio. We didn't talk about ultrasound, but if you have a skilled provider there that can do that, I don't know the sensitivity and specificity on that, but MRA is sensitive, but you don't have the luxury of putting somebody in a scanner for 30 minutes or so if you're thinking that there's an injury. So arterial injuries, this is just kind of a little algorithm. So reduce the knee is the first goal, right? And then physical exam with ABIs. If they have a pulse and normal perfusion, normal ABIs, which is greater than 0.9, then that is somebody that you can observe. If there's any discrepancy, if the ABI is less than 0.9, then that warrants further evaluation, imaging, CT angiogram. possible consult with Vascular. Obviously, if they don't have pulses and there's hard signs of vascular injury, that's going to get an immediate exploration. But kind of circling back to the observation. So it's really important to, as I mentioned before, serial document their exam. Usually what happens so I had a 16-year-old kid that was a high school football player coming across the middle of the field, got hit. He was a tight end, and you could see his knee shift, and he was loose on exam. I knew he had a multi-ligament knee injury. He did have a peroneal nerve palsy, which we'll get to in a minute. And in my mind, anyone with that type of energy, they get a trip to the emergency department. They need to have ABIs done. And that's what we did. We sent him there. ABIs were normal. His exam was, his neuro exam was normal the entire time. I'll get to his nerve exam. And then he was observed in the emergency department for several hours. And then he wasn't necessarily kept as an inpatient, but he was sent out, and then he followed up with one of our sports guys the next morning, which really was, within, a few hours, and by the time he got out of the emergency department, less than 8 hours anyway. And so there's some debate about whether they need to be kept inpatient for observation. I think if there's any concern or any change in their exam, certainly they do need to be observed inpatient or observation for about 24 hours. Otherwise, they need to have very close follow-up, and that's somewhat debatable, but at some point they need to be. These aren't people that can just kind of fall through the cracks or disappear. And so let's talk a little bit about the outcome. So in this study that was out of Mayo, they showed that those with vascular injuries, as you would expect, had much lower IKDC and Lysholm scores than those who did. So this is, again, kind of setting up expectations early on, is that that there is worse function if you do have arterial injury. So our patient, the basketball player, had normal ABIs and no hard signs. So would you go ahead and do a CT angio? Would you watch them in the hospital? Would you just follow their exam? What are your thoughts, anybody, as far as what we should do with our women's basketball player?
I guess the beauty of the CT angio is you don't have to admit them for observation.
Yeah, that's a good point. So certainly cost and radiation exposure, all that comes into play as far as risks, but the risk of missing an arterial injury is certainly it's bad. So, and you're right, in this case, getting a CT angio, and if that was normal, then you'd be much more comfortable letting that patient go home than admitting them to the hospital and doing serial examinations. Other comments? All right, good. So another Bill quote: "If you're born poor, it's not your mistake, but if you die poor, it is your mistake." So let's get over to the nerves. So nerve injuries are fairly common if you look for them, which you should be. So anywhere between 4 and 50% in studies, but mostly it's kind of 18 to 22%. So about 20% of multi-ligament knee injuries have nerve involvement as well. Usually the peroneal nerve, as we know, that's a stretch injury typically, and it can be disrupted. The nerve can be disrupted, not in continuity, but most of the moderate kind of medium energy trauma that we're seeing there, it's a stretch injury. MVC is obviously going to be higher. Increased incidence with lateral injuries, grade 4 ligament injuries, and then, as I mentioned, in the obese. And just like arterial injuries, you might not realize it until 24, 48 hours after the injury. So, role for MRI and EMG. Well, they're going to be getting an MRI for the ligament at some point, but as far as looking at the actual nerve, it may not be helpful because usually these are in continuity. EMG we'll kind of talk about, but acutely there's not a role for it. Here's just a picture of the up near the fibular head. You can see the anterior and lateral musculature here, and you can see the common perineal nerve as it's traversing the wound, and then the lateral cerulocutaneous nerve posterior there. And so another big diagram showing what to do if there is a nerve injury. So if there's an open nerve injury, obviously that's going to be explored right away. If it's a closed injury, then typically you document and you observe and wait and see how it's going to respond. Now, if it's not in continuity anymore, if the nerve is lacerated, for instance, that's not going to just get better on its own, and that often leads to nerve grafting more acutely. The ones where there is a complete nerve palsy and it's not showing any signs of recovery, there are options for that as far as grafting, and then even on the backside, you could do tendon transfers, etc. But really kind of the sweet spot for doing a nerve graft is sort of within around 6 months. So you want to give it a few months, but you don't want to get past a year just because the results of a nerve graft are potentially lower. And so in a center like ours where we have folks that can do this procedure, then you want to work them in earlier rather than later. And if there is a nerve injury, usually it will take months to get better. So this is another thing where you have to again set expectations for the patient. Here's just another little protocol, and that kind of that also has some of these numbers that you'll see. So if there's an incomplete perineal nerve palsy, so they have greater than 1 out of 5 strength. Those are 87% of those achieved essentially full strength on muscle manual testing. So you can tell patients pretty reliably that if they have an incomplete nerve injury, there's a pretty good chance that they're going to get their nerve function back. If there's a complete nerve palsy, this paper quoted 38% achieving greater than anti-gravity strength, and really only about 12% or so had full strength. So, this 16-year-old that I saw on the field where he had a perineal nerve palsy, he had a complete perineal nerve palsy, and on the field, or after we got him off the field, his parents were asking me about that, and I basically told him that there's a small chance that he gets full function back, but he may never get 100% of his nerve back, and that's that's hard news for a parent to hear, or a kid, especially if they are planning on playing at the next level and all this. So, but again, that's another thing that you want to reach that sooner rather than later as far as expectations regarding recovery of the nerve. But if there's a complete nerve palsy, they say 38% greater than anti-gravity strength, but really it's probably 10% get near full strength. So incomplete good, complete bad, obviously. If there is nerve injury, do the simple things. Get them an AFO. Don't let them end up in Aquinas. Physical therapy. You can try neuromuscular stimulation. Back to our exam, the patient had normal neurovascular exam, normal CT angio, normal nerve function, so they could go home. MRI showed ACL, PCL, MCL, lateral meniscus, but the corners were intact. Success is a lousy teacher. Seduces smart people into thinking they can't lose. And this says, yes, that's my surgeon, the one who cuts himself shaving. So most of these are going to be operative, right? So the non-operative patients, they're sedentary or there's comorbid conditions. The patient that Dr. Scott and I saw was BMI 60. Those aren't great surgical candidates for a couple reasons. One, increased complications and OR time, and two, you could fix everything perfectly, but the second they step on it, they're going to stretch everything out or re-tear. So the patients that are poor operative candidates typically will immobilize and work on some of those other factors if they're correctable before considering moving on to surgery. So here's a case, 69-year-old gentleman stepped off a ladder, landed awkwardly on his leg, heard a pop, couldn't walk, felt like his knee was unstable. He had a pretty big effusion. He certainly didn't have all his motion. He had about 10 to 9 degrees. He was tender over the medial and lateral side, and also had loose anterior drawer and Lockman and a pivot shift. So fairly unstable injury, but he's 69 years old, very active. This is just looking at his MRI here. The lateral and medial side were high-grade sprains, but they weren't completely disrupted. Here's his ACL. So ask a question to the group. So what is the next most appropriate step in treatment? Is it immediate operative reconstruction of the ACL, physical therapy for range of motion, bracing and extension, non-weight bearing with crutches, or delayed reconstruction of the ACL, MCL, and LCL? Any thoughts? Next most appropriate step in treatment.
The answer is C.
C. So I like this question because it's a little bit debatable. So what I actually did was I worked on therapy for his range of motion, and I don't think bracing extension is necessarily the wrong answer, because that is certainly an option. But I let him range. I thought that he could get motion back and then basically see how stable or unstable he was. Now, he's also 69, so I was not thinking that I was going to have to do something on him. For the collateral ligaments, some people do brace and extension. So I'd be interested if Charlie or Rick, are you on? What do you typically do for the collaterals? Do you brace an extension, or do you have any comments on that? If they're on.
I'm on. I can jump on the side. Yeah, I like the early range motion program. And I think for a little bit depends on what's going on and how unstable they are. As far as whether I would brace them in extension, if I felt like they have like it could dislocate easily, like if there's significant gross instability, then I would brace them in extension. But if I examine them and it's kind of like I feel like they have a multi-ligament injury, but it's not like gonna just easily dislocate, then I would do physical therapy for range of motion. So like most of the lower energy ones, let's say somebody has a fall and it's a multi-lig, but it doesn't look like a dislocation, then I would just work on range of motion. And if it was an obvious dislocation and it looks like there may be some gross instability, then an extension would be the most stable.
Aren't you still going to brace them in a hinge brace though?
Yeah. Yep.
Sorry, I messed this up.
Quick question. How long would you keep them in extension?
Personally, I would, if I was going to keep them in extension, I would do it for anywhere from maybe 2 to 4 weeks, and check them again and see how unstable they were. If they had started to, for instance, this gentleman, they're going to actually tighten up pretty quickly, just from a soft tissue standpoint. And so I probably wouldn't have done it more than a couple weeks, at least initially, and then reevaluated. Sharon, anything different?
Yeah, usually if I feel like someone is significantly unstable and I'm bracing them in extension, I just do it for a week. I'll tell them in the ER, or I'll tell the resident on call or whoever's evaluating, I say, put them on a knee immobilizer. I want to see them next week in clinic. And they get stiff amazingly fast. And so the big problem with a lot of these is trying to get their motion back. And if you leave them locked out, my experience, at least with the ones that I see, is if I leave them locked out in extension for much more than that, a lot of times I'm not having to worry about a reconstruction. I'm just worried about getting their motion back. If they're left immobilized too much longer than that, at least that's what I've kind of experienced. So I don't know. It's a delicate balance because you move them too fast, like they seem like they get more unstable. A lot of it has to do with how high energy the injury was also. If like everything gets torn, the capsule's destroyed, they're dislocated, like those knees often just lock up and you have to work really hard to get motion.
Dr. Bowman?
Yeah.
Do you feel some of the debatability in this is that, unlike the typical KD classifications, this isn't bicruciate? It's kind of like a 1.5. It's bicollateral, but one cruciate.
This specific case, you're saying?
Yes, this one's.
Yeah. So right. So if he had completely torn the, all those ligaments, then yeah, he would have been more unstable. I would have been more likely to keep him probably in extension for a little while. But yeah, I'm with Jaron that a lot of times these get stiffer a lot quicker than you would expect, especially kind of the older they are, and motion is really what's going to be more important to them in the long run. If you're not thinking that you're going to have to do a reconstruction anyway, then that's why I would err on the side of motion. All right, so let's talk a little bit about the outcome. So operative does better than non-operative in most cases. So how do we treat these? Well, most complete are treated surgically, of course. Now, temporarily, like we sort of discussed, if the knee isn't fully reduced, then you may need to temporize it, either in a brace or in an external fixture if you really can't, grossly keep it stabilized. And then we get into debates about whether to stage or fix everything together. If you stage, you're going to typically fix the collaterals and the capsule first, and then come back and fix the cruciate ligaments. A single stage is what most people are sort of moving to for most cases, and that's a single surgery where you fix everything at the same time, usually 2-3 weeks after the injury. And then the order you want to do is fix the PCL first, then the ACL, and then the collaterals, and that prevents over or under reducing. So timing, we talked about. Graft options. Obviously, the more ligaments you're doing, you're going to be using allograft, cadaver graft. So you have to think about what grafts you're going to use, and technique-wise, your tunnels, you don't want them to converge, and so where you put your tunnels is important, and sort of the order you do that. And then you got to think about the posterior lateral, posterior medial corner. So obviously, you get to some of these multi-ligament knees, and you can get quite a bit of hardware in the knee. So as I mentioned, optimal timing is probably around 2 to 3 weeks if you're going to do it in one step, and allows the capsule to heal, which is going to allow you to keep the fluid when you're doing the arthroscopy portion of it. Allows you to watch any vascular or neuro injury, and if they have any other injuries, to stabilize. Once you start getting 3-4 weeks out or so, you start getting more scarring, loss of landmarks, and it may be a little more difficult. So timing a review, in this study, this was in 2015, that staged cohort did better than the acute, which was less than 2 weeks, or the chronic, which was more than a month. So in that study, they were looking at, they liked more the stage. But then there's been other studies as well that showed that basically there wasn't any difference between doing everything at one time versus just in a semi-delayed 2 to 3 weeks rather than acute or chronic or the staged. So here's another case, 16-year-old I saw. He was playing basketball. His knee went out, and he had grade 3 valgus. So he had a medial injury as well as with the ACL. And here you can see his MRI. ACL is torn, and then on the right image you can see how wavy the MCL is, and the distal attachment of the MCL was disrupted, and distal disruptions like this, they just don't heal back reliably. Proximal ones, they can be treated non-operatively a lot of times, or even high-grade partial mid-substance. Those heal, but the distal ones, they don't heal very well, or they'll heal loose. So this was his exam. And then here's the valgus instability there. And so ended up doing an ACL and MCL repair on him. And for the repair, I usually, I'll put a suture tape as well with it. But those are nice to acutely repair because those should heal back. And then he had a BTB ACL reconstruction. Here's a 52-year-old. He was actually about 9 months out from a MVC, had a knee scope, had a meniscus tear that was debrided. And pain-wise, he wasn't really having much pain, but he said his knee felt very unstable. Every time he would step off a curve or something, his knee would shift. And sure enough, he did have a ligament injury. And because he was imaged a little bit late, I don't know the exact details behind who saw him first, but they basically missed the ligament injury and focused on the meniscus. But he had an unstable exam as well. And here's his instability there. And that's what was bothering him the most. So he ended up with an MCL reconstruction using an allograft, and felt much more stable after that. I won't get into the details of the surgical details of reconstructing the corners, but there's different techniques to reconstruct the fibulocollateral ligament, popliteus tendon, and several different techniques have been described. Posterior medial corner, the semimembranosus has a very broad insertion, and there's a rec soccer guy that I saw a couple months ago, and he had a PCL injury with a posterior medial corner injury, which was really unique. Only found a couple of case reports of that, and so basically when I went in to repair it, his semimembranosus had torn and retracted a couple centimeters, and so ended up repairing the posterior deep MCL along with the semimembranosus, and he's still early post-op, but it was just a very unique and interesting injury, but something you don't see too common is the posterior medial side, but it's there. Usually it's a capsular injury, and you got to look for it. So as far as multi-ligament reconstruction, as I mentioned before, you start to get a lot of tunnels, you start to get a lot of hardware in the knee, but these are just some examples. PCL doesn't have to be reconstructed. So in small series, leaving the PCL alone, actually, they deem to be acceptable, but these are basically case series. There really aren't any big studies looking at these multi-ligament knee injuries and, what do you do for the PCL, et cetera. With the corners, if you have a lateral injury, those actually do a little better than if you have a significant medial injury. So as far as what's on the horizon, what do we do at the PCL? Typically, if you're there to fix the ACL, you're going to fix the PCL anyway. If it's just the PCL and say maybe a partial MCL injury, those are ones that you can usually leave alone. Even when you reconstruct the PCL, it's not very gratifying because they're always a little bit loose. You rarely get them back to normal as far as tension on the PCL, at least in my experience. Repair of MCL avulsions and using suture augmentation, those are some newer techniques that have been described to prevent stretching out of the medial side. Arthritis, so it's also important as far as expectations to tell people what to expect from an arthritis standpoint. 10-year follow-up, 42% of multi-ligament knee injuries ended up with KL2 or greater changes compared to 6% on the non-injured. So certainly a higher risk moving forward. And it didn't seem to be associated with cartilage or meniscus injury at the time. So that was a little bit surprising to me. Age was actually the best predictor, so greater than 30 you were more likely to have arthritis. Now rehab, it varies based on the injury and what your goals are. If you're operating versus non-opting somebody, and we already touched on that a little bit. That was one of the points I was going to bring up, is about the extension. If you're doing if you're doing a PCL as well, multi-ligament, then typically you will brace them in extension for a period of time, and then sort of add passive flexion up to about 90 degrees, and getting them into therapy early, but obviously they're going to have a little bit slower rehab to get back, because you don't want to stress out the ligaments too early. So the women's basketball player, she had a delayed ACL reconstruction. She had allograft. She also had partial lateral meniscectomy, and PCL was intact, and the MCL was stable. And she retired from basketball. So, which is unfortunately what happens in a lot of these players, is that after they rehab back and they just don't feel 100%, they just can't perform at the same level. So here's just kind of a summary slide that shows, look at the nerve, look at the vascular exam. If there's anything concerning or emergent, that's going to prompt further imaging, consultation, OR. Most of the time we do the delayed reconstructions. So in summary, be wary of the multi-ligament injuries. Many of them spontaneously reduce. ABIs, if there's any question, just send them to the emergency department if you don't have the capability, but you get some ABIs. And then CT angio, if there is, again, significant concern. It may save them a stay in the hospital. But if everything else neurovascular-wise looks stable, and you can closely follow them, that may be an acceptable option as well. Repeat neurovascular exams, and then of course operative intervention is favored for most of these. So 2 more quotes. Be nice to nerds, chances are you'll end up working for one. And if you think your teacher is tough, wait until you get a boss for the kids. All right, so there's your CME code again, 32025. All right, any questions?
Dr. Bowman, thank you for that. Just wanted to hear again, in the case of an individual who may have had a self-reducing multiligamentous injury, and if they had normal ABIs in the emergency department, is it the presence of other signs of neurovascular injury, the peroneal weakness that would prompt your CT angiogram, if there, or just the presence of hemarthrosis alone? What was that indication for doing that with negative ABI?
The CT angio?
Yes, sir.
Yeah, so it's a judgment call, I'd say. If ABIs are abnormal, then I think that's a clear indication. Of course, if they're normal, it's debatable. So I don't know if Dr. Gregory is still on the phone, but that's certainly a gray area for me. Typically, I would just serially examine them and have close follow-up, but I don't think it's wrong to get a CT angio in that situation.
I would agree with what you said, that if the ABIs are normal, then a CT angio is not indicated.
As a little follow-up, I coincidentally saw our shared patient who was non-operative. And as you mentioned, she started off with some flicker of peroneal function, and she has a majority strength back, just a little less dorsiflexion and eversion than the opposite side, but still intact, just subjectively weak. And so she's performed well. She just had, she's undergoing bariatric surgery and still has a sense of varus instability.
Yeah, Jaron assisted with that one as well. Certainly, it's good to have multiple opinions when you see an injury like that, in somebody like that especially. Jaron, do you have any comments?
Well, those patients that are, my experience with patients that are obese is that I think our ligament reconstructions are just not like the screws, the what we can do to stabilize it isn't adequate for someone that's really overweight. And my experience is when I've done reconstructions on people that are obese, they loosen up every single time. And so I don't feel like I'm helping them much. So I try to tell people, like, you really have to lose the weight first, and then we can do the reconstruction. You're going to have to do bracing. You're going to have to try to get by. But I feel like that's their best option, is to wait till they lose the weight and then do the reconstruction.
I think that speaks to the sometimes, especially a newer provider may have fear about waiting too long, thinking that they have to jump into surgery or refer into surgery. Clearly watching out for neurovascular injury, but outside of that, we do have a little bit of time, and I think Dr. Cox spoke to that last week, how posterior lateral corners can be repaired later with still reasonable results.
Yeah, I agree. That's it's hard to be patient when you're, especially as a young attending. You want to fix things and you want to help people because they're hurting. But I think that's something that Dr. Sullivan taught me, is that these patients, they're going to be better off if they wait. Don't get too anxious to do something that, right now it's their problem, as far as their instability. But then as soon as you touch them, it becomes your problem. It's now you've messed up their leg, or your surgery failed. And so, yeah, it's certainly good to get multiple opinions and wait till the right time.
Yeah, those are super hard cases. I think it's really good to get multiple evaluations on them, because like with this girl we're talking about, she was in a ton of pain and just begging to like have something done. And it's hard to just say like, no, you need to lose weight first. But I think that again, when you see somebody that you've reconstructed and you've drilled a ton of holes in their knee and then they get loose, like the likelihood of getting it tight another time is just so minimal. And most of us also see people with multiple ligament issues that don't have any pain and they get around okay in bracing. They just get tired of the bracing. So it's good to remember also that, you know, a lot of times these ligament injuries don't cause pain, and you know, they do in certain people, but they don't in others. So it's difficult. Getting multiple opinions is a good idea.
Yeah, that's another good point, especially if it's more of a chronic issue, like that 52-year-old gentleman I saw. If they're complaining of a lot of pain, I'll tell them, I don't know if I can help your pain. I can help instability. I don't know if I can help pain.
Great lecture. Thanks.
Yeah, thanks everyone for your input, feedback, and 32025 is that code if you need it.